So, welcome everyone to this pharmacology rapid revision session brought to you by the NLC, the Next Learning Platform, the best online and offline coaching institutes for the FMG students. I'm your pharmacology educator, Dr. Arpit Agarwal, and welcome you to this session. Okay, so Dr. Najib, Abhi, Sanjay, Divya, good evening, all of you. I hope the audio and video is clear. Hmm? Dr. Ravi, Dr. Artist. Today we are going to discuss some of the most important MCQ for the upcoming FMG examination. So over the next 2 hours, we will go through some of the most important points in pharmacology, and I have structured this session collecting some of the most important MCQ, and you will find that the questions are interesting and also important. So Dr. Ajay, I'm fine, absolutely. So let us start. Welcome Dr. Aditya, Priyanshi, Himanshu, Anjana, Nishant, and Itachi Salman. Good evening RKS. So we have this very interesting session coming up. So let us start. So first kind of questions that we will discuss are related to drug overdose or toxicity. Now in this sessions, I have compiled approximately 10 MCQs related to the important drug overdoses or toxicity. Now, you all will agree with me that in the exams, the topic of drug overdose, their treatment, their symptoms is becoming very, very important. So, let's start with some of the questions from the important toxicity of the drugs. So, first question on your screen, very important question. We have a patient who is being treated for a psychiatric illness. Welcome, Dr. Salman. A patient being treated for a psychiatric illness. He presents with coarse tremor, dysarthria, and ataxia. So, coarse tremor, ataxia. He also complains of increased thirst, polydipsia, and weight gain since last 2 weeks. True regarding his treatment is. So, you are given the presentation, and this should make you think about an important drug overdose or toxicity, this important symptoms that the patient was taking it for psychiatric illnesses. Image is blocking the question. Okay, just a moment. Now, I hope the question is now clearly visible. The question should be clearly visible now. Yes, the question is visible. So we have a patient who is being treated for a psychiatric illness. So that is our first hint that the drug is being taken for a psychiatric illness. He presents with coarse tremor. So coarse tremor, dysarthria, ataxia, increased thirst and weight gain. True regarding the treatment. True regarding the treatment is sodium ion is the specific antidote. Hemodialysis is most effective. It is a case of tricyclic. TCA stands for tricyclic poisoning, and thiazide is the drug of choice. So what is your answer? Give me the answer. So yes, Dr. Sunshine, Himanshu, Najib, everybody is correct. We are looking at a case of lithium toxicity. We are looking at a case of lithium toxicity or overdose. So when the serum level, the first point is when the serum level goes above 1.5 milliequivalent per liter, then the toxicity starts. The lithium toxicity occurs. Lithium toxicity occurs. The symptoms, the symptoms are coarse tremor. Patient will have ataxia. So neurotoxicity, please remember, is the most important. Neurotoxic features like ataxia, dysarthria, tremor. Now coming to the treatment. Sodium ion is the specific antidote. This is false. There is no antidote of lithium toxicity. So this is false. It is a case of tricyclic poisoning. This is false. Tricyclic poisoning presents with metabolic acidosis, not this. Thiazide is drug of choice. No, thiazide is not drug of choice. So the correct answer. Okay, just wait for a second. There is some lag. Yeah, it should work now. Okay. So the correct answer is hemodialysis. Hemodialysis has to be performed. So hemodialysis should be performed in lithium toxicity, and hemodialysis is performed usually when the level goes above 3.5 milli equivalent, or some of the books also say 4 milli equivalents. So above 3.5 or 4, the hemodialysis has to be performed. That is the life saving measure. That is the life saving measure in this toxicity. It is the lithium toxicity. So remember the first important point, the lithium toxicity. Second question. Second question now. Second question on your screen. I'm sure now you can see the screen very clearly. So we have the second question on your screen. A student a student is brought after an overdose of a non-prescription drug. So non-prescription drug, that means an over-the-counter drug, OTC, over-the-counter, for which prescription is not required. Initial complaints include gastric distress, that is nausea and abdominal pain, but later he develops right subcostal pain. Right subcostal pain, you have to imagine, right hypochondrium, that should raise suspicion of the liver injury. So liver injury, right subcostal, live hypochondrium damage, liver injury. Hepatomegaly is given and jaundice, that are indicative of the liver damage. Best treatment for him. Best treatment. Okay, so yes, Dr. Sunshine, Dr. Rai, Anju, Abhi, we have very good students, very intelligent students joining us. So this is a case of paracetamol poisoning. This is a case of paracetamol. Paracetamol toxicity. Paracetamol is an over-the-counter or non-prescription drug, leads to production of an toxic toxic metabolite is N-acetyl paraquinonemine. N-acetyl paraquinonemine is the toxic substance, toxic metabolite which is formed, and that leads to liver injury, that leads to hepatotoxicity or hepatic failure. And the best treatment, the drug of choice will be N-acetylcysteine. N-acetylcysteine is the drug of choice. Is the drug of choice for the paracetamol poisoning. Remember, the toxic metabolite is called N-acetyl-paraquinonemine. That question also has been asked. That question also has been asked. As Dr. Najib has correctly stated, alkalization of urine. This would have been the drug of choice if it was an aspirin poisoning. If it was an aspirin toxicity or aspirin poisoning, then the answer would have been alkalization of the urine. Remember, alkalization of the urine, it would have been the answer if it were a case of aspirin toxicity. So remember, aspirin is also non-prescription drug, and so is paracetamol. If the question is asking aspirin toxicity, then the symptom that will be mentioned, the earliest symptom is ringing in ear tinnitus. Tinnitus or ringing in ear will be mentioned to you, and ultimately all of you know aspirin poisoning leads to metabolic acidosis. So we will give sodium bicarbonate and alkaline the urine. So very good, Himanshu. Aspirin causes hyperuricemia. Himanshu, aspirin causes hyperuricemia. Please remember, gout perhaps will not be the correct way to say. Next question. Next question. Very good. Everybody is doing very good. Next question. So now we have the next question. Next question on your screen. A young man with known heroin addiction. Heroin. What is heroin? Which class of drug is heroin? Heroin is brought to emergency in unconscious state. On examination, he has decreased bowel sounds. Very important, very important. Decreased bowel sounds. Absent or decreased bowel sound. Depressed respiration, respiratory depression, and pinpoint pupil. This word, pinpoint pupil. This is very, very important. Very, very important. Pinpoint pupil. Pinpoint pupil. Only two common poisoning are possible. Pinpoint pupil. Pinpoint pupil, meiotic pupil, only two important poisoning. One is organophosphorus poisoning and the other one is opioid poisoning. Okay, so pinpoint pupil, only two poisoning, organophosphorus or opioid. Correct. In organophosphorus poisoning, we have to look for all secretions going up. All secretions will increase. Lacrimation, salivation, all secretions will increase. And in opioid, what will be given? What will be given? We will have respiratory depression. We will have respiratory depression. We will have decreased bowel sounds because opioids cause constipation. So bowel sounds will decrease. Bowel sounds will decrease. So we have decreased bowel sounds, depressed respiration. So this is the case of heroin or opium or morphine poisoning. And drug of choice, my friends, drug of choice. Drug of choice in this is an mu antagonist, IV naloxone. IV naloxone will be the answer. Mu receptor antagonist. Mu receptor antagonist, IV naloxone. That is the answer. That is the answer. And if it were a case of organophosphorus poisoning, then IV atropine would have been the answer. IV atropine would have been the answer. Correct? So everybody clear? Focus on pinpoint pupil or meiotic pupil. Focus on pinpoint pupil or meiotic pupil. Only two poisoning. Organophosphorus, opioid. Organophosphorus or opioid. In organophosphorus poisoning, secretions will increase. Secretion, salivation, lacrimation, sweating. Drug of choice is IV atropine. And in opioid poisoning, respiratory depression. And drug of choice is IV naloxone. So two questions clear in one query. We have covered two poisoning. When is naltrexone indicated? Sadiq, naltrexone. Very good question. Naltrexone has two uses. Naltrexone is given number one, oral. It is a slow and long acting given orally. Naltrexone is used, number one, to prevent relapse, to prevent relapse of opium addiction after de-addiction. Listen to me. After de-addiction, we put the patient on oral naltrexone to prevent relapse of heroin addiction. And secondly, this is used. Another use of this drug, another use is in alcohol de-addiction. Alcohol de-addiction, to give up the alcohol. So these are the two uses of naltrexone. Dr. Sadiq, I hope that answers your question. Two uses of oral naltrexone. After de-addiction of opium, we put the patient on naltrexone to prevent relapse. वापस ना आ जाए इसलिए, and to give up alcohol. So very important slide, very important questions. Okay, we have many important questions. This is one important poisoning. Next important poisoning. This came every year. This question comes every year. So now this came in last year, FMG as well as NEET. This topic was repeated in this year's INICT also. So alcoholism, heavy drinking, 40-year-old men, 40-year-old men with long history of heavy drinking, this is given, is brought to emergency in a confused state. That is the word we are looking, confusion. Alcoholism plus confusion, what comes to your mind? Blurring of vision, blurring of vision, ophthalmoplegia. He has ataxia, nystagmus, again a symptom of ophthalmoplegia. Confusion, ophthalmoplegia. What is the treatment of choice? What we are looking here? What we are looking? Yes, Himanshu, vernix encephalopathy is what we are looking, and the answer is thiamine. Answer is thiamine. This is vernix encephalopathy. Thiamine. Vernix encephalopathy. This question is a very important topic. Very important topic. This will come. This will come in this year's exam. I am pretty sure this is a very important topic. So we have some slides. We have a slide to remember. To remember this. So please understand this. Understand. In chronic alcoholics, because of malnutrition, there is inadequate intake of thiamine. B1, vitamin B1 or thiamine, inadequate intake. It can lead to two things. It can lead to two things. One is vernix encephalopathy, another is Korsakoff psychosis. Vernix and Korsakoff. In vernix, the confusion and ophthalmoplegia are the main symptom in vernix. So remember the question said confused state and nystagmus, blurring of vision, ophthalmoplegia. In Korsakoff, amnesia, he does not remember. Anterograde and retrograde amnesia is the symptom of Korsakoff psychosis. And in both, what you have to do is IV thiamine initially and then oral. First of all, in emergency, you will give IV injection of vitamin B1, followed once the patient is stable, you will give oral thiamine to replenish the body stores. So clear everyone? Clear everyone? Vernix encephalopathy, you are looking for confusion. In Korsakoff psychosis, you are looking for amnesia. Very important. Sometimes they ask you in psychiatry to distinguish between them. The drug of choice is IV vitamin B1 or thiamine. Okay. So very important slide, and I hope everybody is now clear. Okay. So give me a thumbs up. Give me a thumbs up if everybody is clear on this point. So far, we have discussed lithium toxicity, paracetamol, aspirin toxicity, opium, opioid, alcoholism. All the important toxicity we are going to revise in the next 10 minutes. Next question. Next question. Next question. DNS, see dextrose could be given, but that is not drug of choice, Dr. Aditya. A drug addict. So question says that we have a drug addict. That is very important. So addiction. Always, sometimes, always the patient who is an addict, when they will come with poisoning. presented with agitation, scratch marks on the body, scratch marks. Why scratch marks? You have to think, why scratch marks? Presence of tachycardia, mydriasis, and hypertension. Likely substance responsible. Likely substance responsible. Tell me now, we have mydriasis with history of addiction. Mydriasis with history of addiction. What important poisoning should you think when you have a dilated pupil? When you have a dilated pupil, what are the important poisoning or addiction you should think? You should think. So I will tell you, in dilated pupil, you should think either of the datura poisoning or you should think of the cocaine. Both are substance abuse problem. I hope you will agree with me. Hmm? Dilated pupil, mydriatic pupil. Two addiction are commonly responsible: datura poisoning and we will have cocaine poisoning. Cocaine, you will have increase in BP, you will have increase in heart rate, and you will have scratch marks because the patient feels the tactile hallucination or the cocaine bugs. Cocaine bugs lead to the scratch marks. So our question is clear. Our question is clear. The answer is cocaine. The answer is cocaine. But with mydriatic pupil, please understand, datura poisoning is also an addiction. Datura addiction is also common in India. So what we will have in datura poisoning? We will have symptoms of atropine poisoning, anticholinergic poisoning. So you will have hyperthermia. Hyperthermia will be given. Correct? Hyperthermia, hot as a hair. Hot as a hair. You will have delirium. Delirium will be given. Mad as a hatter. Delirium will be given. Delirium has to be there. And most commonly, dryness of all secretions. Dry mouth, dry eyes will be given. So I hope everybody is clear. Meiotic pupil to poisoning, OP and opium. And dilated pupil, two addiction are common: datura and cocaine. That has to be very, very clearly known. So the moment you get a question of poisoning, look at what is happening in eye. If eye is meiotic or dilated. So that is very important. So I hope everybody is clear. Okay, everybody is clear. Dr. Bard, hypothermia. No, 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 no. In datura, there is atropine like hyperthermia. Hyperthermia due to absence of sweating, temperature goes up. Hyperthermia. Okay, dryness of mouth. Yes, in delirium. That is correct. Next, next question. We have a 10-year-old girl. 10-year-old girl. He was brought for excitation and delirium. Now you see delirium is there. We discussed in the previous question. Delirium. After ingestion of an unknown substance, her mouth was dry, dryness, delirium. Pupil were dilated. Pupil were dilated. Temperature. Look at the temperature. Temperature normal 37.5. It is 38. Hyperthermia. What is the best treatment? I hope you can make the diagnosis now. You are able to make the diagnosis. I have already told you. What is this? What is this? Yes, this could be a case of atropine or datura poisoning. Yes, very good. Excellent. Very, I can see, I can sense that all of you are well prepared. Well prepared for the examination. So continue your focus. Continue your focus. Do not be distracted by the unfortunate news circulating. Focus on the exam. Focus on the exam. Believe in yourself. Believe in yourself. You all are doing very good. All are doing very good. This is a case of atropine or datura poisoning, and therefore the treatment of choice is physostigmine. That is the treatment of choice. Physostigmine. Very good, Dr. Ajib, Dr. Tanya, everybody, Dr. Amit, Dr. Sampath, Prince, everybody is doing very good so far. Very good. So all of you are well prepared. Do not let your focus shift. You have few days in your exam. Everything is going to be all the good. Nothing wrong is going to happen and you all will pass. So just continue the momentum. Okay. I hope all of you are liking the questions. These are all important poisoning. Next question. Next question. When we talk of poisoning, how can we forget organophosphorus poisoning? So we have oxims. Tell me now this question. Oxims are useful for treatment of which poisoning? Oxims. You all know oxims. Oxims are choline esterase reactivators. Choline esterase reactivators. They are used in which poisoning? Tell me. Paraquat poisoning, parathion poisoning, carbamate poisoning, organochloro compounds poisoning. Which poisoning do oxims treat? Tell me. Carbamates. Think. Oxims are useful for which poisoning? They are cholinesterase reactivators. Oxims are useful for which poisoning? Think. Oxims are useful for organophosphorus poisoning. Organophosphorus poisoning. So which is an organophosphorus compound here? Which is the organophosphorus compound? Organophosphorus, which paraquat, parathion, carbamate, and organochlorines. Which is an organophosphorus here? Parathion. Yes, that is correct. Answer is B. Answer is B. Parathion, malathion. These are organophosphorus substances. Organophosphorus substances. Parathion, malathion. And tell me oxims. Oxims, tell me. They are contraindicated in which poisoning? Tell me answer of this question. Oxims are contraindicated in which poisoning? कहाँ ऑक्सिम यूज करते हैं? ऑर्गेनोफॉस्फोरस पॉइजनिंग में. कौन सा है ऑर्गेनोफॉस्फोरस यहाँ पे? पैराथियन, इंसेक्टिसाइड, फार्मर, कई बार हमने डिस्कस किया है. एंड ऑक्सिम्स आर कॉन्ट्राइंडिकेटेड. कहाँ यूज नहीं करना है? ऑक्सिम्स आर contraindicated in which poisoning? Tell me, oxims are contraindicated in which poisoning? Oxims are, yes, Dr. Adil, now you are getting. Oxims are contraindicated in, contraindicated, yes, Dr. Nabi, that is correct. Oxims are never given in carbamate poisoning. Now, why were you people confused? Why did you people get confused? Oxims are never given in carbamate poisoning. So just few seconds ago, most of you answered this question as C. And now you are saying oxims are contraindicated in carbamate poisoning. So please, as I said, focus. The key word is focus. Do not try to solve questions in hurry. Take your time, 30 seconds per questions you take. Read all the options. Think. If there is slightest of doubt, think again. We do not want to commit silly mistakes. So oxims are useful for organophosphorus poisoning and they are contraindicated in carbamate poisoning. So carbamate is not the answer here. Answer is parathion, malathion, diphlos, taboon, serine, organophosphorus. In carbamate poisoning also or organophosphorus poisoning also. Drug of choice. Please remember in both, drug of choice is atropine. Whether it is carbamate poisoning or organophosphorus poisoning, drug of choice remains as atropine. Okay. So Dr. Sadiq, I hope that clears. Whether it is organophosphorus or carbamate, drug of choice is atropine. But in organophosphorus, we can add oxims. But in carbamate, oxims are contraindicated. Contraindicated. Yes, Dr. Rajiv, farmer poisoning. So I hope it is clear. थोड़ा सा हमको silly mistake avoid करनी है. Why do a lot of students fail? Because they are in hurry. So never be in hurry. There is plenty of time in exam. Okay. Iron toxicity is another. Iron toxicity is another important topic. Which of the following is ineffective, not used in acute iron toxicity? बताइए, बताइए. Yes, everyone. Iron toxicity. आयरन टॉक्सिसिटी में ड्रग ऑफ चॉइस क्या है? पहली बात तो ये iron toxicity, acute iron overdose. We will use an iron chelator, injectable iron chelator. We will use. What is that injectable iron chelator? इनइफेक्टिव पूछा है. इनइफेक्टिव क्या है? आंसर बताइए. इनइफेक्टिव, not used. Drug of choice है injectable iron chelator by the name desferrioxamine. Desferrioxamine is the drug of choice. Is the drug of choice. If this drug is not available, what is the alternative? What is the alternative? Suppose desferrioxamine is not available. So what is the alternative? We use other iron chelators. What is that? Calcium aditate is the alternative. Calcium aditate is the alternative if desferrioxamine available nahi hai. And what is contraindicated? क्या नहीं देना है और आयरन पॉइजनिंग में क्या नहीं देना है? Yes, Dr. Barad and Dr. Adil. Yes, Dr. Najib, you are slightly wrong here. Ball is not given in iron poisoning. British anti-leucite. अब देखिए क्या याद करना है, कैसे याद करना है. Ball, it is an chelating agent. British anti-leucite. Ball, we will remember like this, is contraindicated. Ball is contraindicated where? So AB के बाद क्या आता है? Alphabet. AB is followed by CD. So Ball is contraindicated in which poisoning? Cadmium poisoning. Ball is contraindicated in which poisoning? Cadmium poisoning. Cadmium, A B C D. और CD के बाद क्या आएगा? EF. तो Fe, iron. So this is how you will remember that Ball is contraindicated. Ball is not given. British anti-leucide is contraindicated in CD, that is cadmium poisoning, and Fe, that is iron poisoning. So AB, CD, EF. This is the simple way to remember. Ball is contraindicated in cadmium and iron poisoning. So Dr. Bharat, yes, Dr. Bharat, you are correct. Abhi, yes, you already knew. Very good. Whole bowel irrigation can be done. Dr. Aditya, bowel irrigation, these kind of things can be done in any poisoning unless there is some perforation, otherwise you can do it. Okay, so I hope you have remembered. Where is Ball not given? That is asked. So in cadmium and iron it is not given. So iron toxicity we have done. Digitalis toxicity, very important topic. Every year question comes on digitalis toxicity. So digitalis toxicity treatment, we will see later, is aggravated by all except which things increase the risk of digitalis toxicity? बताइए, what increases the risk of digitalis toxicity? Dr. Milk, whole bowel irrigation can be done in iron poisoning. It can be done. It is not the best thing to do, but it can be done. Now digitalis toxicity is aggravated by all except. Yes, Dr. Sharma, digiband is the drug of choice in severe digitalis toxicity. That is correct, but that is what is not asked here. Nuclear briefcase, very interesting name. You say B. So please remember, digitalis toxicity is aggravated by less of potassium, hypo of kalemia, increases digitalis toxicity. Similarly, less of magnesium, and then you have to remember more or hyper of calcium. So this is what you have to remember. This is a very confusing question. Digitalis toxicity is increased by hypo of kalemia, hypo of magnesemia, and hyper of calcemia. So hypokalemia, hypomagnesemia, and hypercalcemia increases the risk of digitalis toxicity. So what is not going to increase digitalis toxicity? Answer is this: hypo of calcemia. Answer is D. Yes, Dr. Bharat, Dr. Sunshine, Dr. Khushi, you're correct. Dr. Nabi and others. You need to remember this. This has to be mugged up. This is very, 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 very important. Very important questions. Digitalis toxicity is increased by, say with me, hypo of kalemia, hypo of magnesemia, and hyper of calcemia. Hyper of calcemia. And the treatment, drug of choice, which is asked in cases of severe toxicity of digitalis. We give anti-digitalis antibody that all of you know by the name digiband. Anti-digitalis antibody digiband is given. Clear? Okay, everyone. So if you're liking the session, please do not be miser in giving the thumbs up, showering your love. Your love is all we need. So your love, your appreciation is what we crave for. So please do not be hesitant and do not be miser. Show a big heart and show me some love so that I am more motivated to teach you. Good evening, Dr. Murli. Slightly late to join. Next question. Next. So we have discussed many important toxicities. In my opinion, these are the toxicities that you must know before going into this year's exam. Next important topic which has come many times, even in this INICT that came, that is teratogenicity. So very quickly, thank you all of you. Now thank you. That is what. Thank you Dr. Divya, Sadiq, Aditya, Dr. Nescafe. Interesting name you got there. Okay. Okay. Thank you Dr. Najib, Dr. Barat, Dr. Jay, Dr. Krishna, Dr. Gunjan. Yes, Dr. Soni, ventricular arrhythmia due to digitalis lignocaine. Let's start with another topic now, teratogenicity. Very, very important topic. Many questions have come. Every year we get a question. So let's start this topic now. First, all the topics are important. We have a mother with history of psychiatric illness. History of psychiatric illness. Child was delivered abnormal tricuspid valve. Abnormal tricuspid valve, you can see abnormal tricuspid valve. It is very, very atrophied tricuspid valve. Small right ventricle, you can see right ventricle so small. Small right ventricle. Which drug? So we are looking at an anomaly that we call as Epstein anomaly. We are looking at what? Epstein anomaly. And which drug? Which drug causes this? Which drug causes? Yes, everybody is correct. No, Dr. Neeraj, this is not warfarin, this is lithium. Lithium causes Epstein anomaly, that is a right-sided heart defect, abnormal tricuspid valve and small right ventricle. This image will clarify. As you can see, the right atrium has become so large. You can see such a large right atrium and right ventricle is atrophied, very small, and tricuspid valve is defective. That is due to lithium intake. Lithium intake in pregnancy causing Epstein anomaly. Epstein anomaly. Dr. Soni, PDF, etc. This will be available to you on YouTube. If you want, we'll share the PDF also. Do not worry. Okay. Next question. These are YouTube sessions, so you can open them anytime. So they will be available on YouTube. So do not worry. Next, we have another teratogenicity. What is shown here? What is shown? We are shown the scalp of a child. You can see the scalp of the child, and there is patchy loss of skin. This is loss of skin, and the scalp of the child is shown. So this is loss of skin or non-formation of skin here. So that is called aplasia. Aplasia cutis. That is called as aplasia, non-formation of cutis, skin. Most commonly you are shown the scalp. It can happen on other places also, but most commonly this image is shown. What is the answer? Yes, Dr. Prince, very good. Aplasia cutis. What is the answer? Carbimazole. Correct. Antithyroid drug, carbimazole. Carbimazole or methimazole. Carbimazole or methimazole is the answer. Antithyroid drug given for hyperthyroidism. Okay, so that is aplasia cutis. Another very, very important teratogenicity. Okay, B. Next, 30-year-old mother with history of arterial embolism. Hmm? Look at the history in the mother also. That will give you some idea about what drug mother may have used. So history of arterial embolism. A child with short limbs, nasal hypoplasia. You can see the nasal bone or nasal septum is depressed. Nasal hypoplasia. This is very, very important. Nasal septum is depressed, which is shown here. Calcification in epiphysis of sacrum and tarsal bone. So you can see this arrow and this arrow. This is called epiphyseal stripling. Epiphyseal stripling shown by these arrows in the tarsal bone and the sacrum. What we are looking? What we are looking? Himanshu, you are saying warfarin hydrated syndrome. What is this warfarin hydrated syndrome? You're trying to combine hydantoin syndrome with warfarin. The correct answer obviously is warfarin. This is chondrodysplasia puncta. Chondro means cartilage, dysplasia puncta. The warfarin teratogenicity, which results in depressed nasal bone, depressed nasal septum, I should say, and epiphyseal stripling seen on the X-ray. So this is the teratogenicity caused by warfarin. Warfarin. Okay. Thank you, Dr. Mahir. Thank you. Thanks a lot. So this is, this question, this depressed nasal bone. This was recently asked. This was recently asked. So this is a very, very important feature. Depressed nasal septum shown like this because the cartilage formation is affected by warfarin. So chondro cartilage dysplasia occurs and depressed nasal bone. This everybody should know. This is very, very simple but very important. So thank you, Dr. J. I am happy that you could learn something new today. That is what is the aim. Teratogenic abnormality. This is spina bifida, and I hope everybody would be able to answer. Everybody would be able to answer this one. This is very, very simple. Teratogenic abnormality, spina bifida, or we can say neural tube defect. Neural tube defect. So phenytoin, lithium, valproate, or barbitone. Which one? Which one will cause? Yes, everybody knows this. Valproate. Valproate causes neural tube defect. Neural tube defect causes spina bifida. This is the lesion which is shown, and you can see spina bifida open defect. And for prevention of this neural tube defect, what we will give? We will give folic acid. Folic acid dose. Normally we give 0.5 milligram. 0.5, but we will give 5 milligram. 5 milligram per day if there is history of neural tube defect in previous pregnancy. In previous pregnancy, if the mother had a child with neural tube defect, then you will increase the dose to 5 milligram per day. Normally we give 0.5 milligram. So dose of folic acid is very, very commonly asked. 4 or 5, there is difference of opinion in the books, but whatever it is, 0.4 or 0.5 and 10 times if there is history of neural tube defect in previous pregnancy. Okay. We move on to the next question. I think we are stuck here. Now, we have done the important teratogenicity also. So this session, we are trying to remember, we are trying to revise pharmacology by important subtopics. So one of the important topic nowadays that has been coming is drug toxicity. We discussed approximately 10 important toxicities. Then teratogenicity comes directly or as matched the following or as image based. So we discussed that. And obviously one of the very important topic in pharmacology is side effects of the drug. So let's now discuss some questions based on the important side effect of the drugs. Okay, so now let's start. We have a woman, 19-year-old woman, will be traveling to an area that is endemic for falciparum malaria. Very important problem for India. Falciparum is endemic throughout India. She is prescribed mefloquine for prophylaxis. So we are talking about malaria prophylaxis. So woman has been prescribed mefloquine given once a week for prophylaxis of malaria. She should be warned about which side effect. So she has been prescribed mefloquine. What should the doctor tell her? Which side effects can occur? Tell me. Side effects of important drug. Malaria, important problem. Malaria prophylaxis is very commonly asked. Mefloquine is the drug for long-term prophylaxis in India of malaria. What is the side effect which is important when we talk about mefloquine? It is a ringing in ear, tinnitus, vivid dreams, blurring of vision, or photosensitivity. Which side effect should this woman be warned about? Tell me. So everybody says C, D, blurring of vision. C, blurring of vision is not the answer. Maybe chloroquine. Chloroquine, if given for rheumatoid arthritis. Chloroquine in rheumatoid arthritis may cause retinopathy that can cause blurring of vision. But here we are talking of mefloquine. So remember mefloquine, what you have to remember are the neuropsychiatric neuropsychiatric side effects are important with mefloquine, neural and psychiatric. So please remember, sleep disturbance, insomnia can occur. Is it given? No. Strange dreams, vivid dreams. So sleep problems are there, vivid dreams, strange dreams. Is it given? Yes, that is the answer. Further, hallucination, psychiatric problem, hallucinations can occur. And lastly, all neurotoxicity end in seizure. So with mefloquine, neuropsychiatric. Mhm. Okay. So neuropsychiatric adverse event, neuropsychiatric side effects are the problem with mefloquine, insomnia, vivid dreams, hallucination, seizure. These are the problems with mefloquine. So remember the answer here is vivid dreams. Primaquine, somebody asked. Primaquine, Dr. J, you asked. Primaquine is absolutely contraindicated in pregnancy. Primaquine is absolutely contraindicated, never given in pregnancy because of the risk of hemolysis. Hemolysis will occur in fetus. Hemolysis will occur in fetus because fetus, please remember it is very simple. Primaquine is an oxidizing drug. Okay. And fetus is deficient in G6PD. So primaquine will oxidize the RBC and lead to hemolysis in fetus. So primaquine is absolutely contraindicated in pregnancy. Okay, I hope that answers your question, Dr. J. Again, I think we're stuck. Seems to be some network issue here. So with mefloquine, remember the neuropsychiatric adverse event, and with primaquine, remember the hemolysis, especially in pregnancy. So it is absolutely contraindicated. Absolutely contraindicated. Okay, so next question. 34-year-old men Dr. Abhi, chloroquine can be given in pregnancy. That is correct. Chloroquine, if mother is suffering from Vivax malaria, then chloroquine can be given. Primaquine is not given. Primaquine is not given. A 34-year-old man who was prescribed fluoxetine SSRI for depression has stopped taking the drug. Because it was affecting his sexual performance. Sexual side effects with SSRI are well known. He also has difficulty in sleeping. If you decide to change the drug in this patient, the best choice would be, so there is a patient who is having depression. He is taking SSRI, fluoxetine for this. He is taking SSRI or fluoxetine for this, and he has been experiencing sexual side effects. He has been experiencing what? Sexual side effects. So he wants to change the drug. He wants to switch the drug. He has stopped taking SSRI. He also has difficulty in sleeping. If you decide to change, the best choice would be, yes, tell me, what will be the answer here? What will be? So, minimal sexual side effect. Amitriptyline, bupropion, fluoxetine, and mirtazapine. So, minimal sexual side effect. Which antidepressant? Look at the options. Look at the options. Bupropion has minimal sexual side effect and so does mirtazapine. This question is not that simple. Bupropion, NDRI. You did not focus on this. Bupropion and mirtazapine both have least or minimal sexual side effects. So now you need to tell me. Now you need to tell me what is your answer. Minimal sexual side effects are seen with both of them. Both of them lead to minimal sexual side effects. Minimal sexual side effects can be seen with bupropion, which is an NDRI, NA and dopamine reuptake inhibitor, and mirtazapine, which is the NASA. So tell me now, which is your answer? Which is your answer? So now we need to think ahead. We need to think ahead. So please remember bupropion. Bupropion here is a CNS stimulant. It causes insomnia. And mirtazapine has a side effect of causing sedation. Mirtazapine causes sedation as the main problem. Too much sleep occurs. So now in this patient we can see he also has difficulty in sleeping. Along with sexual problems, he is also having difficulty in sleeping. So what do we want? We want insomnia or sedation? I hope the answer is clear. We want sedation, and that is why in this question answer is mirtazapine. In this question the answer will be mirtazapine. Okay. Bupropion is anti-smoking, that is correct, but that is not relevant to this particular question. Here what we need to remember, bupropion is a CNS stimulant. Insomnia, anxiety, epilepsy, seizure, these are problems with bupropion, while mirtazapine is a sedative. So this patient also has difficulty in sleeping, so that is why mirtazapine is the answer. Otherwise bupropion also has very minimal sexual side effects. So I hope that is clear now. I hope you have remembered something new today. Bupropion and mirtazapine both have minimal sexual side effects. Next, a patient with hypertension. A patient with hypertension is taking enalapril, amlodipine, and trimethoprim. A patient is taking ACE inhibitor, enalapril, amlodipine, that is a calcium channel blocker, and trimethoprim. Trimethoprim is a potassium sparing diuretic. Potassium sparing diuretic. What adverse effects might occur with this combination? बताइए. ACE inhibitor, calcium channel blocker, and potassium sparing diuretic given for hypertension. What adverse effect might occur with this combination? What kind of adverse effects do we anticipate with this combination? Yes. So whenever we combine ACE inhibitor have a side effect of causing hyperkalemia, and trimethoprim, which is a potassium sparing diuretic, also causes hyperkalemia. So when you combine them, we are looking at risk of hyperkalemia. So that is the answer. Option number A. Everybody is correct. Yes, very good, very good. Simple question. Let's move on. Patient underwent surgery. Patient underwent surgery. During recovery, he was shouting with hallucinations. During recovery, that means once he came out of anesthesia, he was shouting with hallucinations. Which is the likely cause? This question came 2 years ago in your exam, in the FMG exam. Patient underwent surgery. During recovery, he was shouting with hallucination. What is the diagnosis? What has happened here? What is your diagnosis? So these are all clinical scenario questions where you are not asked directly, you are asked to make the diagnosis, and then you can think about the drug responsible. So during recovery, he was shouting with hallucinations. Tell me, what is the answer? Yes, Dr. Bharat, Dr. Medico, yes, everybody. Very good, very good. So patient is showing phenomena of emergence reaction. Emergence reaction, and that is seen with ketamine. That is seen with ketamine. Ketamine is the answer here. Ketamine, very, very good. Dissociative anesthesia, ketamine. Ketamine is the answer. It is the emergence reaction which occurs when patient comes out. When patient comes out of the ketamine anesthesia. So ketamine is the answer. Very good, Dr. Ahmed, Dr. Abhi, Dr. Karishma. Very good, Dr. Adil. Very good. Let's move on. Now we have a patient who took some drug for treatment of acute migraine attack. Acute attack of migraine. After this, he developed change in color and numbness of the tip of thumb. Change in color and numbness of the tip of thumb after taking a drug for acute attack of migraine. What is the likely drug responsible and its treatment? Okay, what is happening here? Patient is having migraine. He takes a drug for attack of migraine. Post this, he develops the tip of the thumb change in color and numbness. What has happened here? What has happened here, and which drug is responsible? Is it option A, dihydroergotamine, and the treatment is sodium nitroprusside, or sumatriptan and nitroprusside, or propranolol and nitroprusside, or propranolol and phenoxybenzamine? What has happened here? What has happened here? Yes, I can see A and B. Some of you are going for B, most of you are going with A. So this is patient developing what? Digital. Patient has developed digital vasospasm. Digital vasospasm, which if untreated, may lead to gangrene also. If untreated, but right now it is digital vasospasm that has caused cyanosis of the tip of thumb and numbness. Loss of sensation has occurred, and this is caused by nothing but ergot-amine. So ergot derivatives are notorious for causing digital vasospasm, which can lead to gangrene. And we will give a very potent vasodilator, nitroprusside. So this is the answer. So remember, attack of migraine, patient can develop digital vasospasm in the fingers because there are no collaterals in the tip of fingers or thumb. So these are end arteries, they undergo spasm leading to digital gangrene, and the causative is dihydroergotamine, and treatment will be done by nitroprusside. treatment will be done by nitroprusside, ergotamine. Yes, okay. So Dr. Govinda, welcome. No problem. We still have a lot of questions to discuss. So this is another important side effect. Now, next question. A patient taking alendronate. Alendronate is taken. It's a bisphosphonate taken for osteoporosis. Taken for osteoporosis. He was advised to take large amount of water and remain in the standing position for at least half an hour. So take the large amount of water after taking the drug and keep standing. These instructions were given to reduce the risk of. Why? Why he was advised to keep standing and drink a lot of water after taking this particular drug? Why? So that is what we want to know. These instructions were given to reduce the risk of cholelithiasis, gallstone, constipation, erosive esophagitis, or osteonecrosis. Why these instructions are given? By these instructions, yes, I'm looking at Prince, Medico, Dr. Jeeb, Manisha, yes, Aman, Janki, yes, everybody is correct. Erosive esophagitis, that is the most common side effect of the bisphosphonate therapy. Bisphosphonate therapy, bisphosphonate, especially the oral ones, cause erosive esophagitis. So drink a lot of water and keep standing for at least half an hour after taking the drug to reduce the risk of erosive esophagitis. That is the question. That is the important side effect of alendronate or bisphosphonate, the drug of choice for osteoporosis. Remember, alendronate is the drug of choice for osteoporosis. Bisphosphonate, causing what? Erosive esophagitis. Erosive esophagitis. Next, a very important and very confusing, which is a side effect of thiazide but not of furosemide. Simple, one-liner question. Which is the side effect of thiazide but not of furosemide? Thiazide, moderately sealing diuretics. Furosemide, high sealing diuretic. Which side effect is caused by thiazide but not by furosemide? Is it hypoglycemia? Is it hyponatremia, hypokalemia, or hypercalcemia? Simple, one-liner side effect. One-liner question, but very important. क्या करते हैं थायजाइड जो कि फ्यूरोसेमाइड नहीं करता है? हाइपोग्लाइसीमिया, हाइपोनेट्रीमिया, हाइपोकैलीमिया, हाइपरकैल्सीमिया. बताइए. Yes, I can see two kind of responses here, C or D. Dr. Pesh is saying D, and Dr. Vanmati is saying C. Most of you are saying D, so that is correct. So two side effects are different. When it comes to the side effect, what is different? Thiazides cause hyper of calcium, while furosemides cause hypo of calcemia. So thiazides cause hypercalcemia, while furosemides cause hypo of calcemia. So that is the answer. Another side effect, thiazides cause sexual dysfunction. Sexual side effect. Erectile dysfunction can occur with thiazides, and furosemides cause ototoxicity. Ototoxicity. Thiazides are not ototoxic, furosemide is. Thiazides cause sexual problem, erectile dysfunction. Furosemides do not. But the important one is thiazides cause hyper of calcemia and furosemides cause hypo of calcemia. Hypo of calcemia. Yes, Dr. Abhi, thiazides help in calcium retention. They reabsorb calcium from urine, while furosemides cause loss of calcium in urine, resulting in hypocalcemia. So that is a very important side effect, very commonly asked. Very commonly asked side effect. Okay. Dr. Barad, you were slightly wrong in this. Not hypokalemia. Hypokalemia is caused by all the diuretics. Next question. A patient with atrial fibrillation. We have a patient with atrial fibrillation is placed on long-term amiodarone. Amiodarone, the class 3. The class 3 anti-arrhythmic drug. The class 3 anti-arrhythmic drug given for atrial fibrillation. What should be assessed periodically in order to detect adverse effect of this drug? What should be assessed periodically in order to detect side effect of this drug? So what will you monitor as a physician? What will you monitor when the patient is taking long-term amiodarone therapy? That is the question. Placed on long-term amiodarone, what will you assess periodically? What will you assess periodically? Will you check blood triglycerides or cholesterol? Does this drug cause hypercholesterolemia, hyperlipidemia? Hearing threshold, audiometry, is it an autotoxic drug? Prothrombin time and anti-nuclear antibody, does this drug have a risk of causing SLE? Will you measure the anti-nuclear antibody? Or will you measure or periodically monitor pulmonary function and thyroid hormone status? What will you monitor? What will you monitor? Yes, everybody is good. Yes, we are good. Very good. No, Dr. Aditya, we will monitor. Amiodarone causes pulmonary fibrosis. Amiodarone causes pulmonary fibrosis, so we will monitor pulmonary function test. And amiodarone causes the thyroid disturbances, hypothyroidism. So we will monitor thyroid hormone status. Okay, so answer is D. The correct answer is D. Because of the ability of the drug to cause fibrosis in the lung and hypothyroidism, pulmonary function and thyroid hormone status. Anti-nuclear antibodies. Anti-nuclear antibodies will be measured if there is a risk of SLE. If there is a suspicion of SLE, and which drug can cause side effect of SLE, which antiarrhythmic, you will remember the drug procainamide. Remember this, procainamide. So that is very important. Procainamide. Okay. Serum potassium levels. I don't think, Dr. Sampath, in amiodarone there is nothing much about potassium. Audiometry you will probably do if the patient is taking quinidine. Quinidine is autotoxic, causes tinnitus, ringing in ear. So autotoxic nature is there with quinidine, the class 1 antiarrhythmic. So you will probably measure or perform audiometric assessments. So procainamide may cause SLE, measure anti-nuclear antibody. Quinidine may cause tinnitus, autotoxicity, perform audiometry. Amiodarone causes pulmonary fibrosis, measure pulmonary function test. These are the three most important antiarrhythmic drug and their side effects. So in one question you will remember all of this. Okay. Next, which anti-cancer drug is not correctly matched? Not correctly matched to its side effects. Doxorubicin causing cardiomyopathy. Nitrosourea. Nitrosourea are drugs like carmustine, lomustine, delayed bone marrow suppression. Procarbazine hemorrhagic cystitis. Bleomycin, flagellate pigmentation of skin. So which is not correctly matched to its side effects? Badai. All are anti-cancer drugs. In anti-cancer, side effect of anti-cancer drug is the most important, most commonly asked topic from anti-cancer pharmacology. So four drugs are given. Doxorubicin, cardiomyopathy. This is correct. Anthracycline or doxorubicin cause CHF and cardiomyopathy. Nitrosourea, drugs like carmustine, delayed bone marrow suppression. Correct. Bleomycin, flagellate pigmentation of skin, very commonly asked. Correct. Procarbazine, hemorrhagic cystitis. This is wrong. Hemorrhagic cystitis is most likely caused by cyclophosphamide. So that is why this is the wrong match. Procarbazine does not cause the bladder damage. Cyclophosphamide is the drug that causes. Yes, Dr. Ashish, that is correct, and Dr. Najeesh, that is also Prince. Procarbazine. Remember, if procarbazine, the side effect is asked, then most likely it will be disulfiram-like reaction. The drug causes disulfiram-like reaction, so please avoid alcohol. Please avoid alcohol if the patient is taking procarbazine. So with procarbazine, the important problem that is asked is disulfiram-like reactions. So avoid alcohol. Hemorrhagic cystitis is a problem of cyclophosphamide or ifosfamide. Okay. So I hope everybody is clear. SGLT2 inhibitors, very important topic. Drugs which increase glucose flow in urine, gliflozins, dapagliflozin, canagliflozin, empagliflozin. All these gliflozins are SGLT2 inhibitors. They're used for diabetes. Yes, that is correct. All are side effects except. क्या नहीं करते हैं? क्या नहीं करते हैं SGLT2 inhibitors? New class of drugs, gliflozin. All the names end in gliflozin, dapagliflozin, canagliflozin, empagliflozin. So they are new drugs for diabetes, act in kidney, prevent glucose reabsorption. What are their side effects? Weight loss, Fournier's gangrene, UTI risk, or lactic acidosis. Dr. Aditya, metronidazole also causes disulfiram. That is correct. Metronidazole, cefoperazone. Cefoperazone is another important drug causing disulfiram-like reaction. Very commonly asked. Yes, very good. Lactic acidosis is a known side effect of metformin. Lactic acidosis side effect goes up with metformin, not with SGLT2 inhibitors. Not with SGLT2 inhibitors. These are other side effects which are seen with SGLT2 inhibitors. SGLT2 inhibitors. So they increase the risk of UTI, vaginal candidiasis. Fournier's gangrene is an infection of the perineal region, infection of the scrotum, the perineal region, the region around anus. Infection occurred that is called Fournier's gangrene, and weight loss is an important feature of SGLT2 inhibitors. Lactic acidosis is a problem rarely seen with metformin. Fenformin is a banned drug, so we do not discuss that. Which should be monitored? Which should be monitored if linezolid is given for more than 14 days? So linezolid, a protein synthesis inhibitor, binds to 50S ribosome and inhibits initiation of the protein synthesis. Inhibits initiation. Protein synthesis inhibitor antibiotic by the name linezolid binds to 50S ribosome, inhibits protein synthesis. The initiation is the step that it inhibits. So what should be monitored if linezolid is given for more than 14 days? So if chronic linezolid therapy is given, will you monitor liver function test? Is the drug hepatotoxic? Is the drug nephrotoxic? So that would need us to monitor kidney function, platelet count, or audiometry. What will you monitor? What will you monitor? So side effects of linezolid. Side effects of linezolid, number one, it is going to depress bone marrow suppression. Bone marrow suppression leading to thrombocytopenia, neutropenia. That is the most important problem with linezolid. So bone marrow suppression leading to thrombocytopenia, and that is why platelet count should be monitored. That is the answer C. Yes, very good. Dr. Autumn Snow, I wish there could be snow in autumn in this part of the country. Dr. Rupesh, Medico, Ashish, Jay, Dr. Yadav, Prince, Nabi, everybody, very good. We are very good students. I am sure all of you will clear the upcoming examination with flying colors, because you all seem very confident, very knowledgeable about pharmacology. So it gives me really immense pleasure. At NLC, it is our endeavor, it is our duty, हमारी कोशिश है कि आप सब लोग जितनी जल्दी हमेशा सक्सेस ले, हर एग्जाम क्लियर करें and become very successful doctor. And right now I can see that all of you are quite prepared. But अब बस last कुछ दिन है, just keep the focus, do not distract, just stay focused, and I'm sure all of you will pass the upcoming examinations. So linezolid, bone marrow suppression, thrombocytopenia, neutropenia, monitor blood counts. Next question. Which antiretroviral drug does not cause peripheral neuropathy? Anti-HIV drug, antiretroviral drug. Which antiretroviral drug does not cause peripheral neuropathy? does not cause peripheral neuropathy. Which antiretroviral drug? कौन सी है? Yes, Dr. Aditya, I'm sure. Yes, Dr. Pesh, we have more questions. Do not worry. The questions are not going to end, and this is going to be a 2-hour session. We'll discuss more important topics. So let's start this one. Which antiretroviral drug does not cause peripheral neuropathy? Is it emtricitabine, stavudine, diadenosine, zelcitabine? All are NRTIs. N nucleoside reverse transcriptase inhibitor. All of them are NRTI, which does not cause peripheral neuropathy. Which antiretroviral drug does not cause peripheral neuropathy? That is the question. So please remember. Yes, let me see. Yes, very good, very good. All these three drugs, all these drugs cause neuropathy. Emtricitabine, which is nothing but a long-acting lamivudine and emtricitabine are same drugs. Lamivudine is given twice a day. Emtricitabine is given once a day. They are the safest NRTI. They are called the safest NRTI because they do not cause peripheral neuropathy. Do not cause peripheral neuropathy. Do not cause peripheral neuropathy. So that is the answer. Emtricitabine. Emtricitabine. Okay, so that is the answer to this particular question. Safest NRTI. This question was asked, or this topic, emtricitabine, was asked in this year's INI-CET also. So remember, emtricitabine or lamivudine are safest NRTI. They do not cause peripheral neuropathy. Next question: all drugs are correctly matched to their side effects except. We are given the anti-glaucoma drugs. Anti-glaucoma drugs are given, and which is not correctly matched. So match the following. Match the following is becoming a very important topic nowadays. So which is not correctly matched? Let me see. Apraclonidine, lid retraction; brimonidine, sedation; beta blocker, nasolacrimal duct blockade by beta blockers; and dipivefrin, heterochromia iritis. Tell me which is not correctly matched. Which is not correctly matched to its side effect. All drugs are correctly matched except. Tell me. Apraclonidine, lid retraction; brimonidine, sedation; beta blocker, anal duct blockade; and dipivefrin, heterochromia iritis. Yes, correct. The answer is dipivefrin causing this. It is incorrectly matched. Heterochromia iritis is caused by the prostaglandins. Prostaglandins alpha like latanoprost. Iris pigmentation or heterochromia iritis is a side effect of prostaglandin analogs. Dipivefrin causes the side effect that we cause as black deposits on conjunctiva. Okay, black deposits on conjunctiva are side effects of dipivefrin. So that is incorrectly matched. Prostaglandins, Dr. Ashish, that is correct, and Dr. TKS and everybody else. Dr. Anju, yes, prostaglandins cause heterochromia iritis. Next one. So this is an image-based question. I hope everybody would be able to answer which anti-glaucoma drug causes the side effect shown in picture. So this is just an extension of the previous MCQ. Extension of the previous MCQ. Anti-glaucoma drug causing what is shown. So what is shown? This is the pigmentation of iris. This is the pigmentation of iris, the brownish pigmentation. So that is called heterochromia iritis because the iris color changes amongst the eye, iris pigmentation. And this image is showing the eyelashes lengthening or growth of eyelashes. Eyelashes are becoming, as you can see, longer. So lengthening of eyelashes and iris pigmentation. So both the eye color will change. That is called heterochromia iritis, something that we discussed in the previous question. So I hope now everybody is clear what is heterochromia iritis. Iris pigmentation, the brownish pigmentation that you can see, that is the side effect of latanoprost or prostaglandin analogs. Okay. So very commonly asked this particular question. Heterochromia redis and lengthening of eyelashes. Lengthening of eyelashes also shown. Okay, so I hope everybody is enjoying. Everybody is finding the session useful. These are some of the most important and frequently asked questions. Next, when we talk of glaucoma, and side effect, we cannot forget timolol, beta blocker. So all of the following conditions get worsen. All of the following conditions worsen after beta blocker or timolol administration, except all of the conditions will worsen after the beta blocker or the timolol administration for glaucoma. So Dr. Max, come length inflammation. Yes, Dr. Max, that is a good mnemonic that you made. Prince, yes, bematoprost can be used for growth of eyelashes, that is hypotrichosis. So tell me this one. All of the following conditions worsen after timolol administration, except. Do not forget except. Bronchial asthma, hypertension, depression, and diabetes. So what is the answer to this question? What is the question? So beta blocker side effect. Beta blocker side effect. Beta blocker worsen asthma, that is correct. Beta blockers can cause depression also, that is also correct. So depression will worsen. And beta blockers worsen diabetes, that is a commonly asked topic. So answer will be hypertension. Answer will be hypertension. Beta blocker actually are useful. You all know beta blockers are antihypertensive. So hypertension will improve. It will not worsen, hypertension will improve. Okay. So all others, asthma, depression, diabetes, they will worsen by beta blockers, but not hypertension. Hypertension will improve. Correct. Dr. Upesh, Max TT 3T3H. Okay. Which drugs can cause torsades de pointes? Very important topic. Very important topic. Torsades when QT interval goes above 450 milliseconds, then a polymorphic ventricular tachycardia occurs, that is called torsades de pointes. Which of these drugs can cause? Which of these drugs can cause torsades de pointes? Torsades de pointes. We have another half an hour of interesting questions left. So please continue to share this session, share the link live with all your friends, invite them, let them also participate. So continue to share and like the sessions. We have more than 100 more than 150 participants live and only 63 likes. That is a bit of uh, not so great thing. So request everybody to first like the session. That is very essential. So do not forget to like the session, also share it. 125 दोस्त हैं और 60 लाइक हैं, तो this is not correct. This is not correct. So which can cause torsades de pointes? Very important question. Torsade de pointes is caused by class 1A drugs and class 3 drugs. Class 1A are known as queen, that is quinidine, Protex, that is procaine, amide, and discopyramid, that is disopyramid. So queen, Protex, discopyramid is the mnemonic. Quinidine, procainamide, disopyramid, class 1A drug. Answer is this. And class 3 drugs are remembered by the simple mnemonic of AIDS. Simple mnemonic of AIDS. That is amidron, ebutilide, dofetilide, and sotalol. Amidron, ebutilide, dofetilide, sotalol. So two mnemonics you have to remember. Queen, Protex, discopyramid, class 1A drug, and AIDS, amidron, ebutilide, dofetilide, sotalol, class 3 drugs. Class 3 drugs. These are the drugs, anti-arrhythmic drugs causing torsades de pointes. And for treatment of torsade de pointes, I hope everybody is aware, magnesium sulfate is the drug of choice. Magnesium sulfate is the drug of choice. Thank you, Dr. J, Dr. Janki, and Dr. Vandana, everybody Dr. Aditya. Double thanks to Dr. J for liking it twice. Okay. So these are drugs causing toxics. Very important topic. Magnesium sulfate is the drug of choice for toxics. Next, very important, simple question nowadays, but the image some of you might not have seen. This is a patient who is being treated for rheumatoid arthritis, progressive visual loss. Fundoscopy shows concentric zone of hypopigmentation. Identify the cause. Concentric zone of hypopigmentation. You can see this is hyperpigmentation. Then there is hypopigmentation. This kind of appearance. This is called what? This is called bull's eye. Bull's eye maculopathy. Bull's eye maculopathy, as you can see, bull's eye maculopathy, and that is caused by nothing but chloroquine. Very important, chloroquine. And please remember, it will happen on chloroquine more than 5 years of use. It will not happen in weeks. When chloroquine is given for more than 5 years, then chloroquine slowly deposits in eye, then it happens. So it will never happen in a patient who is receiving chloroquine for malaria. For this to occur, long-term use of chloroquine, more than 5 years of use has to be there. So please remember, this will happen only in rheumatoid arthritis when chloroquine is given for many years. It will never happen in malaria. Okay, so very important image. Another very important image, flagellate pigmentation. Flagellate pigmentation, as you can see, the flagella-like appearance of pigmentation. Flagellate pigmentation. Very commonly asked, flagellate pigmentation as shown in the figure. What is your answer? Bleomycin, minocycline, vincristine, or daunorubicin? Again, we are moving to anti-cancer drug, flagellate pigmentation. बताइए flagellate pigmentation क्या है? Flagellate pigmentation. Yes, Dr. Shagufa. Yes, welcome. Dr. Ashish. Very good. Very good. Bleomycin. Bleomycin is the answer. Bleomycin. Bleomycin causes this, and another side effect it causes is pulmonary fibrosis. Pulmonary fibrosis. Pulmonary fibrosis. Both the side effects of bleomycin have been asked. Flagellate pigmentation and pulmonary fibrosis. Two problems with bleomycin anti-cancer drug. Bleomycin. Now let's see some of the clinical scenario based questions. Simple. All these questions I have told you. I'm only trying to bring to your attention how a one-liner question can be converted into a clinical scenario. So we have a 45-year-old male with non-Hodgkin's lymphoma. NHL is non-Hodgkin's lymphoma. He is being treated with which regimen? CHOP regimen. CHOP regimen means C is cyclophosphamide, doxorubicin, H is hydroxydoxorubicin. So H is hydroxydoxorubicin. O is oncovin. Oncovin is another name of vincristine, and P is prednisolone. So CHOP regimen. NHL, non-Hodgkin's lymphoma. He develops hematuria, suprapubic pain, which is the most likely cause. What has he developed? Hematuria, suprapubic pain. What has he developed? What has he developed? So this we have already done. This patient has developed what? Hemorrhagic cystitis. Cystitis means bladder problem, bladder inflammation, bladder damage. So symptoms would be hematuria, suprapubic pain. So this is simply one-liner side effect converted into a clinical scenario type questions, and the answer, I hope everybody is clear, cyclophosphamide. Okay, so this was a simple question. Only thing we sometimes remember only the diagnosis, that is hemorrhagic cystitis, but it is also important to remember what will be the symptoms in that particular diagnosis. That is what we want to understand in this particular question. Dr. Sunshine, vincristine causes neuropathy, not hemorrhagic cystitis. So vincristine is notorious for causing the neuropathy. Similar, another question, same pattern, another question. Try to understand the logic, how one-liner questions are converted into clinical scenario. Now we have a patient who is receiving treatment with ABVD regimen. ABVD. For what? Hodgkin's. Now the patient has developed dyspnea. Chest X-ray, sorry, shows pulmonary infiltration. So pulmonary infiltration on X-ray and symptom is dyspnea. Patient is receiving which regimen? ABVD. For what? Hodgkin's. Likely cause. बताइए इसमें likely cause. So again, we have already discussed this question. We have already discussed. It is just to emphasize that sometimes the simple side effect of pulmonary fibrosis side effect caused by bleomycin can be asked in this format also. B in ABVD is bleomycin. B is bleomycin used for Hodgkin's lymphoma. Okay, so we've already discussed bleomycin causing pulmonary fibrosis and flagellate pigmentation, but this is how simple one-liner question converted into a clinical scenario. Next, we stay with cancer side effect, but we move on to hormonal treatment of cancer. So we have a post or pre-menopausal woman, pre-menopausal female, partial mastectomy for a tumor on her breast, so breast cancer. Post surgery, the oncologist recommended tamoxifen, which is a serious side effect of tamoxifen. So tamoxifen, all of you should know, SERM, selective estrogen receptor modulator, SERM, tamoxifen, which is a serious side effect of tamoxifen. Given for breast cancer, the patient is a known case of breast cancer, already undergone partial mastectomy. Now she has received tamoxifen, which is a selective estrogen receptor modulator. What is the problem with tamoxifen? When we are given tamoxifen, what are we worried? Serious side effect is asked. Serious side effect. So thromboembolism is the answer. Correct. That is correct. Thromboembolism. Thromboembolism. Thromboembolism is the answer. So tamoxifen can cause the venous thromboembolism, and tamoxifen also increases, please remember, also increases the risk of cancer of endometrium. Cancer of endometrium risk also increases. So these are the two problems which are asked with this SERM given for breast cancer. So breast cancer के लिए देंगे, or it will increase the risk of cancer of uterus or endometrium along with venous thromboembolism, VTE, venous thromboembolism. These are the two side effects of tamoxifen therapy. Okay, so all important side effects we are covering. We have a schizophrenic patient. Schizophrenic patient started on haloperidol. Haloperidol 2 days ago. Marathon YouTube session. We're doing important pharmacology topics we are covering. We've covered drug overdose, teratogenicity, side effects. So schizophrenic patient started on haloperidol 2 days back. That is the word. Comes back with complaint of torticollis, orofacial lingual movement. Torticollis means spasm of the neck muscle, spasm of neck. Facial muscle are involved. Orofacial lingual movement. What is the diagnosis? What has he developed? What has he developed? This is surely a case of patient getting D2 blocker, haloperidol, and which kind of side effects we expect? We expect extra pyramidal side effect, EPS. EPS, extra pyramidal side effect. Within 2 days, earliest EPS, answer is acute dystonia. Acute dystonia. Within 2 days, acute dystonia. Tardive dyskinesia, abnormal movement, long-term side effect. Long-term therapy has to be there. More than 6 months therapy has to be at least there for tardive dyskinesia. Okay, abnormal movements will be there, tardive dyskinesia, but in long term. This is a case of 2 days. Short term, very quick. Acute dystonia is the earliest extrapyramidal side effect. That is the answer. Yes, everybody, very good. Now let's look at some of the contraindications. Side effects we have completed. We have completed side effects of CNS drugs. We have discussed various teratogenicity. We have discussed side effects of uh, drugs for cancer. Now let's look at contraindications. All are contraindications for morphine. Morphine, a drug that you study in pharma also, in anesthesia also. It's a very important drug. All are contraindications of morphine except. All are contraindications of morphine except akathisia. J. Akathisia means restlessness. Restlessness. Patient becomes restless. That is called akathisia. Beta blockers are given for akathisia treatment. Dr. Aditya, long term actually would mean at least 6 months, or it may be many years, but at least 6 months treatment will be there for tardive dyskinesia to develop. Now let's look at all our contraindications for morphine except. Think, where is morphine contraindicated? Where is morphine contraindicated? In except questions, first of all, remove except. If you are confused, remove except. All are contraindications of morphine. So constricts morphine constricts biliary sphincter, so pressure in bile duct increases, so it is contraindicated in biliary colic. That is correct. It constricts biliary sphincter, pressure in bile duct or bile system increases, do not give in biliary colic. Head injury, it increases intracranial pressure, never given head injury. It increases intracranial pressure, never given head injury, so it is a correct contraindication. Morphine causes release of histamine. Histamine will cause bronchoconstriction. So an asthma patient, do not give morphine. Do not give morphine. So all these are valid contraindications of morphine. Again, you are getting confused here. Morphine is not given in biliary colic because it increases the pressure in bile duct. Morphine increases intracranial pressure, so never given in head injury. Morphine histamine release, bronchoconstriction, do not give in asthma. How could you forget that morphine is given in MI to relieve pain? It is given in MI, so it is not contraindicated. It is given in patients of MI. Kaise? How could you forget this? Most of you were initially wrong. MI में इतना दर्द हो रहा है, his heart is getting crushed. He says, elephant is sitting on my chest, so much pain is happening. What is the drug to relieve that pain in acute MI? Morphine. तो morphine is given in acute MI. Aspirin के बाद morphine नहीं देते हैं, सबको पता है. But you got confused here because contraindication, negative, except negative. So when double negative questions come, confusion is natural. So we have to be extra careful. Extra careful. What did I say? Take your time. Do not jump to the answer. Do not jump. Think one by one. Break the question. Remove except. All these are important points that will help you in solving 2 extra question in exam. Silly mistake we have to avoid. Okay. So this is an example of a question that causes confusion. Contraindications for triptan. Triptan drugs given for acute migraine. Sumatriptan. Given drug of choice for acute attack of migraine. Triptan. Contraindications of triptan. So these drugs are 5-HT, serotonin 1B/1D agonist. And what is their side effect? What is their side effect? Vasoconstriction. Vasoconstriction is their side effect. Vasoconstriction is their side effect. So now tell me the answer. Contraindication to triptan is, I have told you, they cause vasoconstriction. They act on 5-HT serotonin 1B/1D receptor. They stimulate this receptor, it results in vasoconstriction. So where these drugs should not be given due to vasoconstriction. These drugs should not be given in ischemic heart disease, correct. They will cause coronary vasoconstriction. Never given a patient with angina or MI. Pregnancy, do not give. They will cause placental vasoconstriction. Placental vasoconstriction, the blood flow to fetus will be compromised. Do not give. Uncontrolled hypertension, never give because the patient drug is causing vasoconstriction, BP will increase. So answer is this. All of the above. All of the above. contraindicated in all of the above. Okay, so vasoconstriction in coronary, dangerous. Vasoconstriction in placenta, dangerous. Vasoconstriction in generalized blood vessels, BP will increase. So that is why pregnancy, angina or MI history, and uncontrolled hypertension, do not give triptan. Do not give triptan. It's a very, very important question. Okay, okay. So now we have covered, I think, all important side effects. Okay. First of all, drug toxicity, important toxicity we covered. Teratogenicity covered. Important side effect covered. Now we're talking about important drug interactions. Some drug interactions are becoming very, very important. They are quite commonly asked. उनको cover करते हैं हम. ठीक है? All of you are ready to cover some drug interactions? Let's start. Let's start one by one. Okay. Again, I think I'm stuck. चलिए. First, drug that require dose reduction when used along with allopurinol. Allopurinol क्या है? Allopurinol. Allopurinol. Xanthine oxidase inhibitor. Xanthine oxidase inhibitor. Allopurinol. Drug that require dose reduction when used along with allopurinol is. बताइए. Which of the drug? Which of the drug requires reduction in dose when used with allopurinol? Allopurinol is a xanthine oxidase inhibitor, a drug of choice for chronic gout that all of you know. But which drug interaction is asked? 6-thioguanine, azathioprine, methotrexate, 5-fluorouracil. 5-fluorouracil. What is the answer? Yes, I can see all of you know it's a xanthine oxidase inhibitor. What is the answer to this question? Dr. Yadav says A. बताइए, इसमें बताइए, थोड़ा सा टॉपिक हमने डिफिकल्ट पूछा है. देखते हैं इसमें. Jay says D. D. Dr. Aditya also says 5-fluorouracil. Yes. बताइए सब, इसमें थोड़ा सा I can see. So answer is B. Azathioprine and 6-mercaptopurine. There are two drugs. Azathioprine and 6-mercaptopurine. 6-MP. These drugs are metabolized. Their metabolism requires xanthine oxidase enzyme. Understood? These drugs are anti-cancer drugs. Azathioprine is immunosuppressant. 6-MP is anti-cancer drug. They are metabolized using which enzyme? Xanthine oxidase. Xanthine oxidase is required for their metabolism. So allopurinol will inhibit this enzyme. So metabolism of 6-MP and azathioprine will decrease. Their level will increase. That will cause toxicity. So we have to reduce the dose. Reduce the dose of azathioprine or 6-mercaptopurine if allopurinol is added. Okay, remember this particular point, that azathioprine and 6-mercaptopurine, they are metabolized by xanthine oxidase. So if you add allopurinol, xanthine oxidase is inhibited, metabolism of these drugs will decrease and their level will increase. That will cause toxicity. So you have to reduce the dose. You have to reduce the dose of these drugs. So that is the one drug interaction. I hope you will now remember that reduce the dose of azathioprine and 6-MP if allopurinol is added. Mechanism I have explained. Okay. Next question. Thank you, Dr. Aditya. Thank you. You're setting the stage on fire. Now, which of the following drugs is most likely to cause additive anemia and neutropenia if administered to an AIDS patient already taking zidovudine. So patient is HIV positive AIDS taking zidovudine. Which drug if you add will cause additive bone marrow suppression? Zidovudine, remember, causes bone marrow suppression. What is that drug? That is what question is asking. What is that drug? Which of the following drug will cause additive more bone marrow suppression if administered to a patient already taking zidovudine? Okay. So what is that drug? Dr. Pi Square says C, ganciclovir. Dr. Sanjay says C. Dr. Ahmed says B. Answer is ganciclovir. Ganciclovir. Ganciclovir is the answer. Ganciclovir is drug of choice for cytomegalovirus CMV retinitis. And this drug also causes bone marrow suppression. This drug also causes bone marrow suppression. So if you add it to zidovudine, excessive bone marrow suppression will occur. Okay, zidovudine also causes bone marrow suppression. Ganciclovir also causes bone marrow suppression. So if you add both of them, then additive bone marrow suppression will occur. So answer here is ganciclovir. Next question, very important question. This particular one asked many times, many times. 60-year-old male with history of angina is hospitalized with muscle pain, fatigue and dark urine. Muscle pain and dark urine. What comes to your mind? Dark urine, muscle pain. Serum creatine kinase was raised, CK was raised, increased in creatine kinase. Now the answer, the diagnosis should be clear. What has happened to this particular patient? What has happened? The patient has developed rhabdomyolysis. Three things are definite: muscle pain, muscle damage has occurred, myoglobinuria resulting in dark urine, and increase in creatine kinase. They suggest rhabdomyolysis. His medications include atenolol, beta blocker, atorvastatin, and aspirin. Addition of which drug precipitated this condition? Addition of which drug? So all statins. Statins again metabolized by the liver enzyme cytochrome 3A4. So statins are metabolized by the liver enzyme cytochrome 3A4, and this liver enzyme can be inhibited by drugs such as erythromycin, such as azoles from antifungal, ketoconazole, itraconazole, such as ritonavir. So at least these three you must remember: erythromycin, clarithromycin, ketoconazole, and ritonavir. They all are important inhibitor of this cytochrome CYP3A4. So the metabolism of statins will decrease, the level of statin will increase, and they will cause more muscle damage. That is what has happened. So this is an interaction between statins and these CYP3A4 inhibitors. Okay, so answer here is A. Okay, Dr. Rifampicin is an enzyme inducer that will not cause, that will increase the metabolism of statin. So this problem will not occur. This problem is excessive statin level leading to muscle damage. Okay. So I hope this one is also clear. This one is also clear, I hope. Okay, let's move on. A 53-year-old man is scheduled to receive vecuronium. Vecuronium is a skeletal muscle relaxant. During abdominal surgery, nothing wrong with that. The dose of dextronium may have to be reduced if this patient is also receiving. Why would we reduce, or why do we have to reduce the dose of vecuronium? That is the question. Why do we have to reduce the dose of vecuronium? Badai. If this patient is also receiving gentamicin, penicillin, brufen, acetaminophen, that is paracetamol. What is your answer? The dose of vecuronium may have to be reduced if this patient is also receiving gentamicin, penicillin, brufen, acetaminophen. Tell me which one of them. Yes, everyone. So the correct answer here is gentamicin. Gentamicin, as Dr. Shubh has indicated, gentamicin is also an neuromuscular blocker. I hope you remember aminoglycosides are neuromuscular blocker. They decrease acetylcholine release. They decrease acetylcholine release, so they will increase the muscle relaxing effect, increase the muscle relaxation effect. So you will have to reduce the dose of muscle relaxant, otherwise excessive muscle relax and diaphragmatic paralysis can occur. Okay, so the property here is that aminoglycosides like gentamicin are neuromuscular blocking drugs. Neuromuscular blocking action is seen with gentamicin or aminoglycosides that will interact with the action of skeletal muscle relaxant. That is the property drug interaction that we have discussed here. Gentamicin, aminoglycoside, neuromuscular blocking drugs. Okay. Now let's take some questions. These were some important drug interactions that are likely to be asked in your exam. Now let's take some questions on the mechanism of action of drugs. Some important mechanism of actions which are routinely asked. Let's take some of these questions. Let's take some of these questions. Okay, mechanism of action. First, which antipsychotic is a partial agonist? Starting with the simple one, partial agonist on D2 receptor. Antipsychotic, partial agonist on D2 receptor. Dr. Arshi, so it can cause general paralysis. Aminoglycosides by themselves alone do not cause muscle paralysis, but if they are added to skeletal muscle relaxant, then they cause diaphragmatic paralysis. There is a risk of causing respiratory paralysis. Yes, partial agonist on D2. Simple question. Everybody, I hope, know. Yes, answer is aripiprazole. The very commonly asked antipsychotic, aripiprazole. Simple question. Answer is aripiprazole. Mechanism of action of statins is statins drug side effect we discussed. Mechanism of action is what we are discussing now. Mechanism of action. Should haloperidol is a D2 blocker, not partial agonist. So keep that in mind. Aripiprazole is the drug that is a partial agonist on D2, not a D2 antagonist. Mechanism of action of statins. Inhibit the HMG coenzyme synthase, stimulate HMG coenzyme reductase, indirect increase in LDL receptor synthesis, and inhibition of intestinal cholesterol absorption. What is the answer? What do statins do? So this is your liver. Statin. They go and inhibit the enzyme HMG coenzyme A reductase. This enzyme is inhibited. Which enzyme? HMG coenzyme reductase. So inhibition of HMG coenzyme synthase, wrong. Option A is wrong. Stimulation of HMG coenzyme reductase, no, they inhibit this enzyme, so this option is also wrong. So again, hurry, not reading the question properly. A or B, all of you are wrong so far. HMG coenzyme reductase is inhibited. So A and B are wrong. When HMG coenzyme reductase is inhibited, it decreases cholesterol in liver. It decreases cholesterol in liver, but liver needs cholesterol. Liver needs cholesterol to form bile salt. So what liver will do? Liver will take cholesterol, let's say this is the cholesterol in blood, LDL cholesterol in blood. So liver will increase the LDL cholesterol receptor on its surface. LDL cholesterol receptor will increase, and through which liver will take cholesterol, and that is how blood cholesterol will decrease. So answer is C. Answer is C. Increase in LDL receptor synthesis. That is what will happen when you give statin. HMG coenzyme reductase will be inhibited, and that will increase the LDL receptor on the liver surface, and that is how cholesterol from blood will be sucked inside the liver. So I hope you have understood how examiner can deliberately confuse you, how options are created deliberately to confuse you, and in hurry you just mark the wrong answer thinking the paper was simple, but actually this is a difficult question. So correct answer here is C. Increase in LDL receptor that causes the uptake of LDL cholesterol from blood, and blood cholesterol decreases. Okay, so please, as I have been telling you, take your time whenever you find a confusing question. Read all the options. 30 seconds you have to give to each question. Do not hurry. So in this small session only you have realized that 3 questions you have, out of silly mistake, out of hurry, you have committed wrong, and that has caused you a lot of marks. 12 marks you have lost. So Dr. Arshi, A and B is confusing. Yes, so that is why if the question is simple, sometimes the options can be confusing. So we have to give due respect to the question. Read all the questions, read all the options, think before marking the answer. That is very, very important. I have given you plenty of examples to illustrate. Take your time. Do not be in hurry. 30 seconds you have to give to each question. 37-year-old man is diagnosed with colon adenocarcinoma. The oncologist recommends the use of bevacizumab. Mechanism of action we are discussing for important drug bevacizumab. This agent, what does this agent do? Bevacizumab blocks intracellular signaling by EGF, epidermal growth factor, inhibits cell cycle progression, induces differentiation of cells, inhibits angiogenesis. What is bevacizumab? Thank you all of you for your kind comments. I'm only trying to bring to your attention the small points. See, you all are knowledgeable. That has been proven today. All have answered the questions correctly. But some silly mistakes sometimes cost us too much. We want to improve not just our knowledge, but be also aware of the silly mistakes that cost us. So that is something that we want to do. So this is an NTV EGF. It inhibits the vascular endothelial growth factor, and by inhibiting this, it will inhibit the angiogenesis or the capillary formation. So capillary formation will not occur. Angiogenesis, that is the answer to this particular question. It is an anti-angiogenic, anti-VEGF vascular endothelial growth factor inhibitor used in colon carcinoma. Bevacizumab. Bevacizumab. Now again, simple question, confusing option. Which of the following antidepressants act by inhibiting reuptake of both serotonin and Na? Reuptake of both has to be inhibited, serotonin and Na. Which of these? Which of these antidepressants act by inhibiting reuptake of both serotonin, that is 5-HT, and Na, that is noradrenaline? Reuptake inhibitor of both. Reuptake inhibitor of both. Fluoxetine, duloxetine, paroxetine, dapagliflozin. So all zetine are given. Again, simple question, difficult or confusing options. So fluoxetine, SSRI, inhibits reuptake only of serotonin, selective serotonin reuptake inhibitor. Paroxetine, again SSRI. Dapagliflozin, again SSRI. It is the duloxetine, which is SNRI. Reuptake inhibitor of serotonin and norepinephrine. Serotonin and norepinephrine is duloxetine. Duloxetine. So please remember, duloxetine is an SNRI, and that is the answer to this particular question. Duloxetine, used for depression, also used, as Dr. Bharat is saying, for stress incontinence. That is correct. But mainly it is an antidepressant, SNRI. Reuptake inhibitor of both serotonin and norepinephrine. Other SNRI include venlafaxine, correct, duloxetine, and milnacipran. Yes, Dr. Max, Dr. Najib, that is correct. Oral direct thrombin inhibitor, very very important. Oral direct thrombin inhibitor. Oral direct thrombin inhibitor. So new oral anticoagulants are very very important topic. Warfarin is oral anticoagulant, but some new oral anticoagulants have come. So oral direct thrombin inhibitor is asked, and oral direct factor 10A inhibitor is asked. These are two new oral anticoagulants. Direct thrombin inhibitor is a drug that we call as dabigatran. That is the answer. And direct 10A inhibitors can be remembered by XA, and we are trying to ban or inhibit it. So apixa, edoxa, and rivaroxaban all end with XA ban. So these are new oral anticoagulants. New oral anticoagulants, whether direct thrombin inhibitor or direct 10A inhibitor. Direct thrombin inhibitor or direct 10A inhibitor. 10A inhibitor can be remembered by XA ban, that is apixaban, edoxaban, and rivaroxaban. And direct thrombin inhibitor or dabigatran. 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 So that brings us to the end of today's session. We have tried to discuss some of the most important topics: side effects, mechanism of action, drug interaction, teratogenicity, poisoning. Under these topics, we have tried to cover the most important drugs which have been asked repeatedly in the recent examination. I've also tried to incorporate, you know, multiple points in the same questions. So that is all we had time in this 2 hour session. I hope that you enjoyed it, and I hope that you liked the questions. You found the session useful, and I was able to communicate not just the important points but some of the other important things that you must keep in mind while you are attempting the exam in the examination hall. So that was the attempt. The session obviously is brought to you by the NLC, the best coaching platform for the FMG examination, and we at NLC are always ready to help you. So whenever there is any doubt, reach out to us. I'm always available through NLC platform, and I wish all of you all the best, and I hope we'll meet again before your exam for some more interesting session. But all of you, like the session and subscribe to the NLC YouTube if you have not already done. Share the links with your friends, and also keep your focus. Do not distract. These are last few days, and we want all of you to succeed, and then we can have a grand party. So with that, I'll say you good night. Take care. Enjoy, but stay focused. Thank you, all of you.